Hey everyone, and welcome to This Explainer. Today we're jumping straight into a true clinical masterclass on hematological and oncological disorders. We're going to bypass all the basic stuff and dive right into the deep end, the complex pathology, the advanced treatments, and most importantly, the absolutely critical safety protocols you need to master. So let's get those clinical gears turning right off the bat. Okay? I want you to imagine this. You just got a lab report back, and your client's platelet count has suddenly dropped to just 19,000. So, what is your immediate priority? What exactly are you going to do in that critical moment? Just kind of let that scenario roll around in the back of your mind as we go through today's material. Because figuring out the deep clinical why behind the answer, well, that's exactly what this masterclass is all about.
All right, here's our quick agenda for today. We'll start with understanding cancer and metastasis. Then, grading, staging, and detection. Third is the pillars of treatment, followed by critical radiation safety protocols. After that, we'll hit bone marrow transplants and wrap up with leukemia and infection control.
Okay, Section 1, Understanding Cancer and Metastasis. Let's get into it.
So, at its very core, cancer is a malignant neoplastic disorder. Essentially, it happens when cells literally lose their normal brakes, that internal growth-controlling mechanism. But, the true danger here is that cancer doesn't always just stay put. Metastasis is what happens when these cancer cells pack up and migrate from their original location to other vulnerable sites in the body. And there are three main highways they use for this invasion. First up, we've got local seeding, which is where shed cancer cells just kind of scatter in the immediate local tissue area. Second is lymphatic spread. This means if a primary tumor is sitting in an area rich with lymph nodes, it's exceptionally susceptible to early migration. But the big one, the most vital route you really need to know, is blood-borne metastasis. Once those tumor cells actually breach the bloodstream, the risk of systemic spread goes through the roof. It is literally the single most common cause of cancer progression.
Moving right along to Section 2, Grading, Staging, and Detection.
Now here's a crucial distinction that trips people up all the time in clinical practice: the difference between grading and staging. Honestly, they represent two entirely different ways of looking at the disease. Grading is your microscopic view. It classifies the exact cellular aspects of the cancer, like how abnormal do these specific cells look under a microscope, how fast are they growing, how much have they differentiated from normal, healthy tissue. Staging, on the other hand, is the big picture, the macroscopic view. It classifies the overall severity, the clinical aspects, and the actual physical degree of metastasis right at the time of diagnosis. So if you want a quick mental shortcut, grading is all about the cell itself, while staging is all about the spread.
All right, let's talk early detection. The CAUTION acronym is just a brilliant, super helpful mnemonic for the 7 critical warning signs of early cancer. Let's run through it. C is for a change in bowel or bladder habits. A is for any sore that just doesn't seem to heal. U stands for unusual bleeding or discharge. T is thickening or a lump, maybe in the breast or anywhere else really. I is for indigestion. O is an obvious change in a wart or mole. And finally, N stands for a nagging cough or hoarseness. Recognizing these early signs, it's a total game changer. It can dramatically alter a patient's trajectory, shifting our whole focus from just palliative management to a potential actual cure.
So if a patient actually presents with any of those 7 warning signs, the whole diagnostic cascade kicks off. And sure, we have countless incredible diagnostic tools out there, high-resolution MRIs, CT scans, specific tumor markers, you name it. But a biopsy remains the absolute definitive means of diagnosing cancer. It's the gold standard for a very good reason. Whether it's a needle aspiration, an incisional wedge, a full excisional removal, or even multiple staging biopsies, actually extracting physical tissue is the absolute only way to get that undeniable histological proof we need to confirm malignancy and start targeted treatment. No way around it.
Let's transition over to Section 3, the pillars of treatment. In oncology, we almost never rely on just a single drug. Instead, we use combination chemotherapy. But listen, this isn't just some random cocktail of meds thrown together. It's a highly orchestrated balancing act. Providers meticulously select these medications so their side effects, and absolutely crucially, their naders, do not overlap. So what's a nadir? It's basically rock bottom. It's the absolute lowest point of bone marrow activity and white blood cell count after a chemo dose. By intentionally staggering these medications so their naders hit at completely different times, we're actively preventing a catastrophic, life-threatening wave of immunosuppression.
Now, while chemo tackles systemic spread, radiation is our precision, localized weapon. And this brings up a literal life or death distinction in radiation therapy. Teletherapy, which is external beam radiation, uses a radiation source outside the body. Because the energy just passes right through, the client does not emit radiation afterward. They pose zero hazard to anyone else. It's totally safe to be around them. Conversely, we have brachytherapy, which is internal radiation. Here, the radiation source is placed directly inside the client in continuous direct contact with the tumor. Because the physical source is literally inside them, the client does emit radiation, posing a serious, ongoing hazard to healthcare providers, family members, everyone.
And that leads us perfectly into Section 4, Critical Radiation Safety Protocols.
Okay, listen up, because when a patient has a sealed radiation implant for brachytherapy, the entire nursing environment transforms. Strict adherence to protocol here isn't just a suggestion. It is a matter of absolute safety for the whole floor. First off, a private room and a private bath, totally non-negotiable. Your primary defenses here are time, distance, and shielding. We have to limit staff time in that room to just 30 minutes per care provider per shift. That's it. You absolutely must wear a dosimeter film badge to precisely track your personal radiation exposure. Pregnant nurses and visitors under the age of 16? Strictly prohibited. No exceptions. Any other visitors are capped at a maximum of 30 minutes a day and have to stay a strict 6 feet away from the patient at all times. Oh, and one more thing. You must save all bed linens and dressings right there in the room until the radioactive source is officially and safely removed by the team.
So imagine the absolute worst-case scenario. A radioactive implant actually becomes dislodged. It falls out. You must act sequentially, and you cannot hesitate. Step 1, command the client to lie perfectly still to stop the source from moving anywhere else. Step 2, never, ever use your bare hands to touch it. You grab long-handled forceps to carefully retrieve it. Step 3, drop that source directly into the heavy lead container that should already be pre-positioned in the room just for this reason. Step 4, get the radiation oncologist on the phone immediately for next steps. And finally, Step 5, thoroughly document exactly what happened. Memorizing this specific sequence? It is absolutely vital to preventing a catastrophic exposure event.
Next up, Section 5, Bone marrow transplants.
To survive those massive high-dose therapies that are meant to completely wipe out malignant cells, we have to find a way to rescue the patient's destroyed blood-forming system. And there are two main ways we get these rescue stem cells. In an autologous transplant, the client actually gets their own stem cells back. We harvest and safely freeze them during a period of disease remission. Pretty amazing, right? But then there's the allogeneic transplant, where the stem cells come from a donor, like a perfectly matched sibling, a parent, or even an unrelated match from a registry. But here's the profound irony of the allogeneic approach. While it is absolutely life-saving, those foreign donor cells bring a massive risk of graft versus host disease. That's where the newly transplanted immune system wakes up, looks around, recognizes the recipient's entire body is foreign, and actually starts attacking it.
All right, our final section. Section 6, Leukemia and Infection Control.
Leukemia is basically this abnormal, hyperaggressive overproduction of immature white blood cells. And it presents this really fascinating clinical pattern when you look at the typical age of onset. For instance, acute lymphocytic leukemia, or ALL, is predominantly a pediatric thing. It typically strikes kids younger than 15. Then you have acute myelogenous leukemia, AML, which kind of bridges youth and adulthood, most often hitting between 15 and 39 years of age. From there, we see a shift toward the chronic types. Chronic myelogenous leukemia, CML, generally shows up in a person's 40s, their fourth decade of life. And finally, chronic lymphocytic leukemia, CLL, is typically a disease of older adulthood, usually emerging after age 50. Keeping these demographics in the back of your head is super crucial for building immediate clinical suspicion when you're first reviewing a patient's history.
Now, because leukemia itself severely wrecks the immune system, and our intense therapies wipe out whatever bone marrow is left, these patients are completely stripped of all natural immunity. They have zero defenses. The brutal reality of clinical oncology is that the major cause of death for these patients isn't actually the leukemia itself, it's infection. This demands uncompromising, practically militant protective isolation. We are talking frequent, meticulous hand-washing by literally every single person who crosses the threshold. A private room with the door firmly closed at all times, strict aseptic technique for any invasive procedures, and, ideally, getting that patient into a room equipped with HEPA filtration or a highly specialized laminar airflow system. You honestly just cannot be too careful here.
To wrap up our masterclass, I really want to leave you with this final clinical thought. If a leukemia patient is deep in their nadir period, remember that critical vulnerable window where their white blood cell activity is essentially at zero. What is your absolute #1 highest priority? Well, as we just established, preventing infection is everything. Rigorous hand washing and strict protective isolation aren't just polite hospital guidelines, they are your ultimate non-negotiable life-saving tools. Think back to our opening scenario with that dangerously low platelet count of 19,000. Whether you're jumping into strict bleeding precautions for those low platelets or uncompromising protective isolation for an absent white count, your rapid, structured clinical protocols are the literal safety net keeping these patients alive. So, what protocol will you master next? Thanks so much for joining me for this explainer, and keep studying hard.